Dr. Alex Singer from the University of Manitoba and the Manitoba Primary Care Research Network, who will be talking about addressing disease risk factors in primary care settings. So, are you there, Alex?
Hello. Let me see if I
Hi,
can
great. Your
share.
microphone's working. Wonderful. Now, I
Are you okay if I
believe,
take over and share?
yes, absolutely.
Okay, I'm gonna do my best.
Alex will introduce himself today.
You can introduce me. Go ahead. If,
Um,
or do you don't have my bio? Do you want me to introduce myself?
Well, I'm curious to know whether it's changed since last year. So last year, Dr. Alex Singer was a practicing family physician, clinician teacher, and associate professor in the Department of Family Medicine at the University of Manitoba, where he served as the Director of Research and Quality Improvement. He was the network director of the Manitoba
Still am.
Primary Care Research Network, where he led and collaborated on several regional and national practice-based research studies. His research focus was on using information technology in primary care settings, specifically in the areas of disease surveillance, virtual care, and pragmatic clinical trials based in primary care settings. He has published and presented on several topics, including quality improvement in primary care, chronic disease management, and resource stewardship in primary care. And Alex is going to tell you how that's changed in the last 12 months.
I,
Over to you, Alex.
it's largely the same. There's a few, of course, as research flies, a few extra things in there. I'm gonna see if I can figure out how to if I can share this properly. Let's see if I get my slides up. Or give me some hassle. Um, can you see the title slide or do you see the presentation mode?
Not yet.
Okay, hold on. What happened? Oh,
Now we are seeing something.
uh, too many screens open. Let's see if this makes it work.
Looks like the Thames.
Title slide?
No, we're seeing your notes.
Ah,
Wait, I'm reading them.
I forget how to flip this. There is a way. Hang on. Where's the share? Sorry. I got too many windows open and it's being funky on me. Oh, where's the Zoom thing? Hold on. Sorry, give me 1 second here. Sorry about that. Let's try again. Let's screen one, screen two. Let's try this. Oh. How's that?
Perfect.
Okay.
Yes. Bingo.
Voila.
Got
I
it.
can't see you. I don't know where my Zoom window went, but I'll
We
keep
can
going.
see your slides. Yeah, great.
You can see the slide nicely.
Yep,
Okay,
beautiful.
I'll keep going and
Okay, thanks,
oh,
Alex.
I think I found there's the Zoom thing. Sorry. Anyhow, I found it. Okay, all good. So yes, nothing dramatic has changed in the last year, other than some of my research is starting to slide into maybe doing some AI type things, as that's sort of where some of the tech that I worked on in the past is going. But this presentation, I'm going to sort of jump back and forth a little bit. It's very similar to the one I gave last year. So some of these things have the technology has obviously advanced quite a bit, as sort of artificial intelligence is advancing, but the principles are very much the same. And many of the things that I'm going to talk to you about, like natural language processing, really when we talk about sort of modern AI, is really just natural language processing with a few extra layers like large language models, and things like that. So just combining different kinds of machine learning and natural language processing all together. That's where AI has gone in the last couple of years. But specifically last year. But in my work, I'm a family doc 2 days a week, and then I'm this research director and the director of this research network. So I'm going to filter back and forth a few times during the presentation about some of the reasons why addressing risk factors and particularly social determinants is so crucial, if we're going to provide good whole person population level type care. And then I'll talk a little bit about some of the technology and some of the informatics pieces. So hopefully that'll keep your attention. And then I'll ideally have some time at the end for questions. So just let's see if I can change the next slide. There we go. I'm talking to you today from Treaty One, and you guys are presumably elsewhere in the country, but this is the place that I get to live and work and enjoy, and it's a really interesting part of the country. And if you haven't made out to Winnipeg or Treaty One territory, then come on down. There's lots of conferences in Winnipeg in the next year. A few conflicts, none of which I'm going to affect the presentation today, but I did do some work funded by a for-profit funder, IBM, but they actually filtered the money through the Canadian Institute of Military and Veterans Health Research. So someone on the call was talking just before about D&D. So I've been to a few CIMBER conferences, so partly related to this work on PTSD. That project has long since wrapped up, but some of the learning has been useful in an enduring way. In terms of learning objectives, I'm going to try to drive home some of the importance of why social determinants and health behavioral risk factors are so important for care, and I'll just give you a bit of a snapshot around that. We'll talk a little bit about practice-based research and learning networks, which is kind of where my world and where my connection to this work is, and so just give you a flavor of how, in Canada at least, PBRNs or PBRLNs, practice-based research and learning networks. If you hear me say PBRN, that's what I'm talking about, or PBRLN, I'll try to get the acronym right. I'll talk a little bit about how the work that I've done and some of the work elsewhere in PBRNs that's done in terms of extracting and processing clinical data. It's a little bit different than some of the sort of data derived that ends up at CIHI, where it's sort of coded and presented and shipped out by the administrative data warehouses. In the sort of clinical world, certainly in primary care, a lot of the sort of cleaning and coding happens in PBRLNs. And then we'll talk a little bit about the future state. Of course, that sand is shifting daily with new advances in sort of artificial intelligence stuff. But I'll tell you a little bit about a couple new studies that I just added in today. So we know that risk factors for acute and chronic diseases include social, environmental, health-related behaviors. So that's not new. Your genetics predict a little bit about what you're at risk of developing in terms of diseases and conditions in your life. But those things are strongly influenced by the environment that you're in and the risk factors that you might take on. And many of the inequities in terms of the risk factors, particularly the social and environmental ones, were really exacerbated by COVID. And COVID, in many ways, for many people, sort of unveiled something that a lot of people that had done this work in the past in terms of epidemiology and certainly in primary care circles was sort of well known, but it became sort of public speak. People during the pandemic recognized that certain areas were harder hit than others, and it was fairly obvious for some reason, in some ways, why those areas, had to do with poverty and, living conditions and, close quarters and people who had essential work, all those things. People who couldn't just take a day off work or work remotely from their basement like I do. So a lot of that became quite clear. And then we'll talk a little bit about, practice-based research networks, as I mentioned, in terms of how we are working towards trying to describe and display some of those factors. So this is hopefully not novel to anyone, but medicine's not the most important driver in health outcomes. You can see that by the map. And that's the city of Winnipeg. The city of Vancouver, Toronto, Calgary, Edmonton, look very similar. What am I doing here? And so you can see, if I find my cursor, that in Winnipeg, which looks a lot like many American cities, the kind of core area is where there's lots of poverty and high concentration of people, and lots of homeless folks and a whole bunch of social determinants challenges. And then as you move out from the periphery, particularly on the south side of the city, so both wealth goes up, but also life expectancy. So there's quite a differential. And so just being in this postal code in here confers a pretty dramatic, it's almost a 10-year drop in life expectancy, both for men and women. And that is well beyond just in terms of access to care. And I mentioned the sort of COVID phenomenon that unveiled a lot of this, right? There's a slide from the Canadian Medical Association, which they've since kind of pulled away from talking about too much, but it just identifies sort of what are the things, your healthcare contributes about 25% of your actual what's going to make you sick. And most of these things, the 50% over here is what's likely going to lead to your whether you're suffer from chronic diseases or not, or how well you do if you're diagnosed with a condition, even things down to the things like that you would think are sort of has no barriers like viruses or cancer, but in fact social determinants do play a role. This is just a different framework to describe that kind of contextual factor of age and constitutional factors, but then they kind of spread across the social and economic and environmental boundaries. So this is a neat little framework from sort of the public health circles that just describe this sort of overall influence. So we know that to be true, but then the problem is if we don't measure it, very hard to manage it. And so in the same breath that I say these things are very important and practitioners, by and large recognize that social determinants play a huge role in outcomes and risk, we don't measure them terribly well. And you can see my Don Berwick quote around soon is not a number, some is not a number and soon is not a time. I like to add to that famous quote that hope is not a plan, because sometimes when we're talking to policy folks, they say, well, we hope this will work. Well, I prefer to measure things and iterate. But so this should be not new to you in terms of informatics, because you guys are doing a master's in informatics, but the concept of garbage in, garbage out. So if we have a crappy training data set or a unclear or a opaque set of data, that we don't get the answers we're looking for, or we can't see what we're looking for. That's true in the world of AI, and that's also true in any kind of informatics, where if the input data, if you put crappy data into a model, you don't get the answer you're looking for because it's not necessarily applicable to the question you're asking. This was a really interesting saga from a couple of years ago in the US, where they were testing out or they weren't actually testing them, they'd actually deployed them, an algorithm to try to determine patients at high risk of poor outcomes. And they used an algorithm that used health service utilization as a marker of who should be getting sort of a patient navigator because they're at higher risk. And it turned out sort of the punchline is that the algorithm was racist. It actually underappreciated patients who were African American or Black, their sort of health complexity. And it did that because it used a payer-based system. And so those folks were more likely to actually not have good coverage. And then therefore they didn't appear to be receiving as much care. So then therefore they didn't qualify for this advanced sort of extra intervention. And it just goes back to the point of, if you're not careful with the data set that you're using, you can skew a finding, or algorithms sort of can only make decisions based on the data they're provided. And so that's in part why measuring social determinants is so important, because if we're going to try to intervene, you need to have good baseline measurements. Father of healthcare informatics, Lawrence Weed, or Larry Weed, is famous for saying coding is caring, trying to convince his physician colleagues to code better and to use a patient-oriented medical record. And I like that quote above. And if you haven't watched any Larry Weed lectures, because he's, I think, long since passed, try to find, there's a couple really classic ones where he's screaming at people, telling them how insane medical records that they're using are. And sometimes that's how I feel, being like, how are we still using a system that hasn't been upgraded in 10 years or 15 years? Like no other industry would tolerate the kind of crap that we do in medicine. But anyway, so that's Larry Weed. And he made this statement in 1968, which, resonates still today. So we'll leave it at that. So now where are we going, and how are we addressing some of these challenges? So that's where we get to practice-based research and learning networks. These are sort of examples. So this is sort of a family of them. I'm the director of the Manitoba one, the Manitoba Primary Care Research Network, which is part of a group, a network of networks. In the center, SIPSN. There's a similar grouping in Ontario so the group in Ontario is SIPSN is part of that. They're part of SIPSN as well. And there's all sorts of reconfigurations happening right now in primary care research, something called the Canadian Primary Care Research Consortium, which is kind of overarching all of these things. But fundamentally, the idea is that practice-based research networks are networks of researchers who connect to practices. In the Manitoba case, we've got 50-something practices that contribute their data and participate in studies, mostly voluntarily. Sometimes just by participating, they can't help but contribute to studies because we do observational work. But things like trials and stuff, we recruit people in. And so PBRNs, in my mind, or practice-based research networks, practice-based PBRLNs, are really a major component to what we might call learning health systems. So they're sort of the grease in the wheels in some ways. They, at least in primary care, are sort of what connects many practices to a data system and to research and learning, sort of that continuous cycle. And that's really what learning health systems are all about. I could give a whole other talk about learning health systems, but suffice to say, we have lots of challenges particularly in primary care, but healthcare in general in Canada. And my sort of belief is that unless we really advance learning health systems, we're not going to be able to make the changes that we need, where otherwise we're just throwing spaghetti at the wall and hoping that our improvements will work and will lead to the outcomes we're hoping for. And the only way to really achieve meaningful outcomes and to improve our health system overall is to build a learning system. And that means part of the fundamental component of a learning system is a data infrastructure that you can use for measurement. And so I hope that most of you, when you go out and get jobs, are able to contribute to that kind of work. And the example of the paper there is that we did some of this work around frailty, which of course is a complex task to manage. And then situated in that is sort of this idea of the patient's medical home, that in primary care, at least, we're part of a bigger ecosystem. Oops. Okay. So what's the role of a PBRLN in sort of measuring behavioral risk factors, and how do we use, I'll just sort of give you some examples of how we actually have used in the past surrogate measures. Because when you get to have large data sets, or when you get to work with large data sets, you often find that you don't have the level of detail or granularity for an individual patient to know their socioeconomic status or things like that. But you can use surrogate measures, and I'll show a few examples of that. And then I'll talk a little bit about how PBRLNs are contributing to sort of learning health system type objectives in terms of that continuous cycle of quality improvement and integrating and using research in practice. So this is some work that initially a colleague of mine did, and then I replicated a version of it doing alcohol. So we'll talk a little bit about tobacco. So the first study was a colleague of mine did years and years ago at this stage, probably 10 years or so, where they looked at who gets asked if they smoke. And then I did a similar version where I looked at who gets asked if they drink alcohol, both of which, of course, are risk factors for diseases. I'll talk to you a little bit about the alcohol one because that's the one I know the best. So we know that, because I did that one. So we know that, I guess I should say, why did we bother, right? I'll ask the question, then I'll answer it. Well, why do we bother looking at it? Well, we know that alcohol contributes to a significant proportion of deaths, at least going back to 2005 when I pulled this data, but I'm sure if anything, it's actually increased. And there's a number of major medical comorbidities that alcohol is related to. And so knowing if you're looking at screening histories or looking at population or predictive measures, if you want to know how many, hepatologists we need in the future, you need to look at who's drinking now, because those people are going to develop things down the road. And having really good data might actually also help us to prevent alcohol dependence, or actually provide targeted strategies, or know where to deploy those things. This is just a good old medical school slide that, says all the things that alcohol does. Basically, anywhere where the alcohol touches, can put you at risk for certain types of diseases. But so who gets asked? So we know that alcohol relates to disease. And it turns out that in the study that we did, only 40% of the patients had their alcohol use documented. And when we observed this, some of the people who had their alcohol use recorded were the kind of patients you might expect. Well, so males are more likely to have an alcohol use disorder than women. So that sort of makes sense. Older people, well, maybe they had more opportunities to be asked. There's also a skew because, I don't ask 12-year-olds if they drink usually. People who saw their doctor more frequently, that's not surprising. More chances to update the EMR. And then things like comorbid diseases, and more likely if they had heavy consumption. So probably because there's some clinicians suspecting that something's going on. But all these were sort of moderate odds ratios. So okay, so the people that we hope would be asked are probably being asked more, and people who come a lot are being asked. That's getting documented at least. Okay, so that's good. The problem is the EMR data is not clean. On the right-hand side there of my GIGO slide, there's just a sample of some of the ways that alcohol use disorder or alcohol use at all was documented. And so you can see all sorts of just kind of nomenclature there, like how physicians write in notes, because most EMRs, just about none, if they have a coded field, it's probably a dropdown, and the dropdown can be changed by the physician often. So you get these kind of, spelling errors and sort of hilarious things and, different kind of ways of writing something, like the word secondary with a 2, and ETOH is sort of medical terminology for alcohol. It's the chemical form. So if you don't want to have to write alcohol, or if you got to spell it, you can just write ETOH. And then you see things like, drinks 5 units per day, which when I say that, you can probably figure out what the acronym means. But this, of course, makes it challenging for computers to do the data cleaning. So we did a different version of this, just to sort of quick tangent. When it comes to medications in the research network that I run, or that I direct in Manitoba, that part of this bigger network, we did this kind of cleanup for medications, where we developed algorithms to take, medication names that usually come from a database and convert them down to a clean text in an ATC code. Because all of the other gobbledygook in terms of how many units and stuff, that's not useful. What we really want is the generic name. If we're doing a study, we want to know all the people on, say, insulin or something. And then those things are coded. Medication codes WHO has a medication coding system called ATC, which you probably know about. It's similar to like ICD-9 or ICD-10 or even 11. So essentially, we developed a natural language processing model where we extracted the data. We developed a reference standard. So we had, actually, for this study, I can't remember if it was medical students or residents, but someone classified the terms, and then we trained an algorithm to sort of onwards and onwards using this kind of bag of words model, where it connected different unigrams, single words, pairs of words, and then the text was processed, and then we were able to sort of, as a result, define out who was a non-drinker, who was a light drinker, who was a moderate drinker, who was a heavy drinker. It's a whole chunk that end up as unknown. But inevitably, we were able to do this at reasonable scale and demonstrate that it was possible. And then we've kind of moved on and done it for a bunch of other things, some of which I won't talk to you about today. Like we cleaned up the allergy table and we did some other stuff like that. We did some work around substance use disorders. And so similarly, this goes back now 5 years. So we looked at this, who had documentation for substance use. This time we had medical students to document, and then we built an algorithm. But I have to fix this slide. So we built an algorithm that then defined out based on which patients had records, and was able to sort of, identify different things, including whether they were drug users or which particular substance. So this is just an example of using sort of an automated detection model. The other thing that happens really commonly in the current state is we use postal codes. So we use, what's going on here? We use postal codes to derive social determinant factors. So this is most reliable for things like SES, or socioeconomic status. And I'll tell you a little bit about how we use postal codes. And there's sort of aspirationally this idea that at some point we'll integrate these things, more directly into digital record systems. We still mostly, for the most part, at least in primary care, use electronic paper records. I use a computer screen at work when I'm seeing patients, but by and large, I'm using that computer as if the things that I'm doing were on paper. So I still fax, prescriptions and lab recs, and I print, things for patients to take to, an X-ray department or whatever. So this was a study looking at automated detection. So using, in a pediatric population, doing this kind of work, similarly building an automated model that sort of used a rule-based matcher. And they were actually able to do that quite effectively. The natural language processing was pretty good, but it added a whole large volume of data that didn't get captured in structured form. So if people put the information, the take home of this is, if people put the information in a structured form, it's much easier for the computers to sort it and for someone to build an algorithm around it. It's much harder when people write sort of nomenclature, although the large language models are getting better at being able to sort of read, discipline-specific jargon. And this is just a graphic of sort of how this study worked, where they kind of, you took the structured indicators and chunked those out, and then the sort of narrative ones, and then ran it through this pipeline of deep learning models. And these deep learning models, this paper was already, is already old. These deep learning models have advanced really quite well, and a lot of the large language models get it pretty accurate, at least for short strings of text. This is what their NLP looked like from this study, and they kind of coded things to SNOMED and other sort of concept terms. And then out came this pipeline where they were able to document, who was a drinker, marijuana, opiates, tobacco. So this work has been done. This is a fancy graph that shows all the sensitivity specificities for the different pieces, but I'm not going to talk too much about that. And then others have. This was a systematic review of different versions, different types of large language or natural language processing. So this is sort of active research, and we're getting closer to being able to sort of take free text and just pump it through some algorithm, and then from that free text be able to say, okay, here's all the people who might consume alcohol, and here's what their risk factor is. So that's kind of ongoing. There's none of it, to my knowledge, is deployed in Canada. Certainly some examples in the US and some centers that use some of this natural language processing. And beyond that, I don't really know. So, but in terms of social determinants, I mentioned sort of postal code use. This is a smattering of studies, and there's 3 of them there, where in my group, we've used postal code as a surrogate measure to give us a social determinant index. And the way this works is, when you fill out your census form, StatScan collects all this data, and then they create these tables that then can derive backwards. So there are errors, let's say, if it's not perfect, but at the population level, when you're dealing with hundreds of thousands of people in a cohort, it sort of comes out in the wash. And so postal code derived social determinants, usually it's at the 6th digit. And so you're talking about sort of like a small area of a street or a single apartment building, that kind of thing. And so for the most part, in urban areas, it works quite well. Sometimes there's a lag if there's sort of gentrification happening in a city. So, you can imagine sort of in a Toronto or a Vancouver, where sometimes a crappy, rundown neighborhood suddenly gets, a facelift and a whole bunch of new condo buildings, and the people that move into those places are actually much wealthier than the, people that have historically lived in that neighborhood. But by and large, these things work pretty well, and they've been validated a number of times. So there's just a couple of examples of where in my research, we've actually used it. So looking at pediatric blood growth measurements, looking at chronic kidney disease, that's what CKD stands for, And then pediatric hypertension was sort of one of the drivers, hypertension being one of the drivers of CKD. So I'll just show you sort of how we've used this data just to give you a sort of a flavor of what it looks like in some of these studies. And so you can see, lots of kids get their blood pressure measured, maybe not necessarily all of them. But then when you actually drill it down, if you look in the least deprived neighborhoods, they actually get their blood pressure. Those kids that come from a wealthier neighborhood get their blood pressure is actually measured a bit more frequently, and it's actually a little bit higher often. Maybe because it's measured more, maybe not. And in the most deprived neighborhoods, you can see this kind of skew. So there's this interesting pattern. Maybe it's because we're measuring them more. Maybe it's just maybe for other reasons their blood pressure is actually a little bit on the higher side. And you can see some other, urban rural doesn't make much of a difference. Obviously, whether they have diabetes, so that they're a bit more likely to be high. But again, you can just see this spread of these kids down here aren't getting their blood pressure measured quite as much as the kids kind of in these quintiles. I mentioned just sort of the indices before. The social deprivation index reflects different things that are around relationships, so family, workplace, the proportion of people in the neighborhood that are divorced, and so it's sort of a surrogate for the sort of the health of the neighborhood or the relationships. It's not always useful in all studies. Material deprivation is a bit more clean, let's say. It's really more about socioeconomic status and unemployment rates, high education rates, and so material index tends to be a bit more reliable indicator, but the social one can take an effect too, and they're not always the same. So in this study, where we were looking at blood pressure measurements, the material deprivation in females wasn't statistically significant, and in males it was. So and the social deprivation wasn't statistically significant at all. So sometimes they're different. Now, in the case of kidney disease, there's this really dramatic skew of folks who are in more deprived neighborhoods, suffer or experience poverty more frequently, are much more likely to have chronic kidney disease, and then that sort of staggers down. So it's almost a 20% difference between folks who are well off versus poor or economically disadvantaged. Your risk of having chronic kidney disease is almost a 20-point difference. And it narrows a little bit. It's narrowed a little bit over the years. It was a bit more divergent back here, but it's pretty stable. And these numbers continue straight through. So I sometimes joke with my nephrology colleagues that dialysis is a poor intervention for poverty, but nevertheless, the health system tends not to address these cases until people are at their end stages, unfortunately, because there's very little you can do I shouldn't say that. Chronic kidney disease is an interesting sort of condition because there's lots you can do in the early stages to prevent it from chronic kidney disease from progressing. But once it's progressed, once you sort of have full stage chronic kidney disease, stage 5, there's not much you can do other than dialysis, which is, not wonderful. In terms of PTSD, you see the same pattern. So this is some of the work we did developing an algorithm to understand PTSD. And just in the same way as CKD, there's a dramatic difference between your risk of being diagnosed, at least with PTSD. And then in PTSD, there's this kind of argument that gets made, is it a chicken and the egg? Is it that people who have PTSD are more likely to be poor, or is poverty putting you at risk? So does having PTSD somehow impair your ability to, be at a higher socioeconomic status? Or is it the reverse? Is there something about poverty that puts you at risk? Spoiler, it's probably both. And so we did this work looking at a huge cohort of 700,000 people, and we showed that there were some pretty dramatic, the material one in this one, and I think the social one as well. Don't know if I have that slide. But again, you can see a big difference in the percentage of people who have PTSD from the least deprived to the most deprived. And it's sort of, these two quintiles don't hold. These are the sort of middle kind of working folks generally, quintiles 3 and 4. But the most deprived has a really a much higher rate of PTSD than in the least deprived. Not that it's absent, but patients with PTSD, quite dramatically different there. And then, of course, that affects annual visit frequency. For, if you have PTSD, you're going to see your doctor a bit more often. And again, this sort of dramatic odds ratio of 2 to 4 kind of thing. And it happens in both. So that, again, for the social deprivation, you could argue that maybe those are some of the risk factors, but again, also some of the consequences. But certainly you see the same slightly lower effect comparing the most deprived to the least deprived. So it's a twofold difference in the material, but almost a fourfold difference in the social. So huge disparities there for a condition that is pretty troublesome. So what can we do to address this? This is some work that I've been part of in Manitoba, and there's a group in Ontario that's led a lot of this work, supported by the College of Family Physicians. And so this is something called the poverty screening tool, or the poverty tool, which we developed a way of automating, I wouldn't say automating, of collecting some of this information and then having a website so that folks could more easily identify what they're eligible for. And then this Get Your Benefits booklet, which is available in lots of primary care centers, to sort of help folks, because one of the amazing things about social determinants is the intervention is a lot of the things that people are already eligible for, but they don't claim. So it's tax season. You hopefully didn't forget to file your taxes. And most people who live in, most folks who are sort of in the sort of 4th and 5th income quintile, if you file your taxes, you tend to actually get money back. So it's actually quite advantageous at the lower socioeconomic statuses. And of course, if you make a lot of money and you pay your taxes, that's good, because then that pays my salary and other people who make an income based on sort of public services, our military friends and whatnot. But also, that contributes to all the programs that support folks who don't that are in the lower SES brackets. And so that's, again, these interventions that also have health benefits. And I think that's kind of the message here, is that intervening with poverty actually has a dramatic health benefit. And so it's worth measuring and figuring that out so we can actually target those things. And it's not just about equity per se, it's actually about outcomes. So I won't give you my diatribe about the quintuple aim. So Kai and others have done some work in this area, and I think Linda's going to be talking to you all about this later. So I'm going to quickly brush over this so we can get to some of the interesting part and let you ask some questions to me. But again, lots of work by others to try to develop technical standards and frameworks, which is not really my expertise, but just to mention that they're happening. These are the Kai elements from last year. I presented this sort of disappointingly to say they're all to be confirmed, and maybe Linda will tell us at the end that they've all been decided upon. But I was disappointed when I found these slides last year, because they were still working on all the social determinants. This is a group, the Upstream Lab, which is in Toronto, that's done a whole bunch of work on this, and also around race-based data collection. They did it during the pandemic, and actually have done a lot of patient engagement to sort of determine what patients are comfortable with. This was some work around called the Spark tool, where they actually directly worked with folks to determine sort of how to get it in the EMR, and what people were comfortable, how they were comfortable being asked about their sort of their experience in terms of poverty or economic, income, education, all these kind of things. This ended up being used to create sort of a tablet-based tool. A lot of clinics now email some of these things or secure message them out to their patients. We did a little study where we tried giving people tablets in the waiting room. It didn't work fantastically. But this is kind of, I think, where some of the world is going in terms of social determinants. So using AI to actually derive the social determinants from the free text gobbledygook that's in people's charts. And so that is sort of an interesting element that's happening and that's going to be happening. This paper was published in 2025, just this month. And this one goes back about a year before, where the same group, in Toronto, the Upstream Lab, they looked at qualitatively what people were interested in knowing, what they were comfortable with. So there was a number of questions about privacy and how do these tools work, and then how best to do it. So they've sort of laid out some standards or some thoughts in the literature about what the best practices are for developing these AI tools to actually derive things, and then what kind of things do patients worry about in terms of trying to get it right. So lots of really interesting work in this area in the future. And I think similar to the sort of stuff I showed you around the behavioral risk factors, we're going to soon start to see AI tools that allow us to derive, some information, maybe maybe complementary to the postal code and the census data, and maybe in some cases, sort of leapfrogging some of that. If the data exists in a narrative node. Because the other piece is that it doesn't always get documented. So we'll see where that goes in the future. If you haven't read it, I feel like this is probably required reading for your master's thesis, the Pan-Canadian Health Data Strategy. Hopefully you'll work towards some of this, and then be part of learning health systems in your future careers. So just a note of inspiration. We have a great strategy and a great plan to do this in Canada. We've just yet to really execute it. And one of the things we're really good at in Canada is writing really great reports that describe things like this, about how we move from the current analog system to a future digital state. I hope to spend some time working on this in the future, and I hope you guys get to do that as well, because and put your training into good use. But we need to get here where the data flows around the patients and it's not belong to the institutions and get handled by administrative data warehouses and then shipped out to people like Kai. We need to get to a point where the data follows the patient, and then we can create a data ecosystem that we can actually measure things more robustly. Get off that particular soapbox, and hopefully I've convinced you that risk behaviors and social material circumstances have a huge impact on disease prevalence and are important to be measured, and that practice-based research and learning networks are kind of part of that developmental phase in the research world of trying to develop how we actually might be able to do these in practice. I will stop there and leave some time for questions. So thanks for listening.